Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 285 of our pharmacotherapy series, which majors in thrombosis. The first question reads, JYT, a 60-year-old, overweight, 92 kilograms, 6 foot tall man, was admitted to the hospital 3 days ago for management of acute cellulitis of his left ankle that occurred after cutting himself with a lawn tool a week ago. He was started on intravenous antibiotics and had limited mobility in the hospital due to the pain at the wound site and is being evaluated by orthopedics for possible osteomyelitis and surgical intervention. On the third day of hospitalization, while the wound was improving, he noted progressive swelling and soreness of the left calf and around his left knee. He denied shortness of breath, abbreviated as SOB, cough, or chest pain. His medical history includes coronary artery disease, diabetes mellitus, and hypercholesterolemia. His medications are lisinopril 10 mg per day orally, isosorbide mononitrate 120 mg per day orally, atenolol 50 mg per day orally, aspirin 81 mg per day orally, metformin 1000 mg orally twice daily, and atorvastatin 80 mg orally every evening. Initial laboratory values include hematocrit of 36.5%, prothrombin time of 10.8 seconds, an INR of 1.0, a PTT of 23.6 seconds, platelet count of 255,000 per microliter. So my question to you is, what signs and symptoms demonstrated by JYT are consistent with deep vein thrombosis, abbreviated as DVT? Patients with deep vein thrombosis typically present with unilateral leg swelling that often is accompanied by warmth and local tenderness or pain. A tender, cord-like entity caused by venous obstruction can sometimes be palpated in the affected area. JYT presented with the sudden onset of swelling along with soreness, but without evidence of a cord. Discoloration of the affected limb, including pallor from arterial spasm, cyanosis from venous obstruction, or a reddish color from perivascular inflammation, may also occur. The presence or absence of a positive Hohmann's sign, pain behind the knee or calf on dorsiflexion of the foot, is rarely helpful in making the diagnosis because it is present in only about 30% of patients with deep vein thrombosis. Many patients, that is more than 50%, can present with asymptomatic disease, but even asymptomatic patients can have long-term complications such as recurrent deep vein thrombosis or post-thrombotic syndrome. Because symptoms of deep vein thrombosis are nonspecific, the diagnosis must be confirmed by objective testing. The next question reads, what risk factors does JYT exhibit that are associated with deep vein thrombosis? The diagnosis of deep vein thrombosis depends not only on the presenting signs and symptoms but also on the presence of risk factors. JYT has presented with obesity and immobilization, i.e., prolonged bed rest, two important risk factors for thromboembolism, as well as an acute medical illness. It is common for more than one risk factor to be present in patients who exhibit deep vein thrombosis, and these factors are cumulative in their effect. The next question reads, how should the final diagnosis of deep vein thrombosis be made in JYT? After evaluation of the signs and symptoms of deep vein thrombosis and consideration of risk factors for the development of thrombus, a definitive diagnosis should be made. Diagnostic strategies should include an assessment of pretest clinical probability, that is clinical suspicion, D-dimer assay, an evaluation of the presence of fibrin degradation products, indicative of clot formation, and non-invasive imaging tests. Despite its limitations as a single diagnostic tool, clinical assessment can improve the diagnostic accuracy of non-invasive testing. A clinical prediction rule, such as the Wells criteria, takes into account signs, symptoms, and risk factors to categorize patients as being at low, intermediate, or high probability of having deep vein thrombosis. The D-dimer test can be used in conjunction with clinical evaluation or a clinical prediction rule to help rule out deep vein thrombosis in patients with a low clinical suspicion and thus decrease the need for imaging tests in these patients. If the clinical suspicion of deep vein thrombosis is high, diagnostic imaging is indicated, and if the imaging is negative, the D-dimer is helpful to rule out the diagnosis. The most common non-invasive test is duplex scanning, which combines B-mode imaging or color flow imaging with Doppler ultrasonography to visualize veins and thrombi while investigating flow patterns. Other non-invasive testing options include fibrinogen leg scanning, injection of radio-labeled fibrinogen followed by scanning to detect areas of accumulation corresponding to thrombosis, impedance plethysmography, use of pneumatic cuffs to detect leg blood volume changes associated with thrombosis, and Doppler ultrasonography alone, use of a transducer to audibly detect venous flow changes indicative of thrombosis. Each option differs with respect to sensitivity, specificity, and cost. Venography, radiographic visualization of the involved vessels with injection of radio-contrast material, an invasive diagnostic test, is the most sensitive and specific method for diagnosis of deep vein thrombosis, but exposes patients to the risks associated with contrast material, and is not readily available in many hospitals. The next question reads, what additional baseline data should be obtained before administering anticoagulants to JYT? In addition to assessing the integrity of the clotting process with platelet count, hemoglobin, hematocrit, prothrombin time, and activated partial thromboplastin time, the patient's baseline renal function should also be evaluated and documented because some anticoagulants are renally eliminated. Baseline values are used for comparison with the parameters that will be used in monitoring both therapeutic and adverse effects of anticoagulant therapy. The next question reads, duplex scanning reveals clot formation in JYT's left calf extending to the left thigh. He does not exhibit signs of pulmonary embolism. So my question to you is, what is the appropriate therapy for JYT, and how should it be initiated? Prompt and optimal anticoagulant therapy is indicated to minimize thrombus extension and its vascular complications, as well as to prevent pulmonary embolism. Acute anticoagulation treatment options include injectable IV unfractionated heparin initiated with a loading dose followed by a continuous infusion, adjusted dose subcutaneous unfractionated heparin, subcutaneous low molecular weight heparin, or subcutaneous fondaparinux. Alternatively, initial treatment with oral rivaroxaban or apixaban can be selected, without any initial parenteral anticoagulation. Low molecular weight heparin or unfractionated heparin may be continued as monotherapy or transitioned to treatment with a vitamin K antagonist, dabigatran or edoxaban. Because JYT is currently hospitalized and may need further surgical procedures, IV unfractionated heparin is selected for initial treatment of his deep vein thrombosis. The next question reads, JYT's medical resident ordered a heparin bolus dose of 5,000 international units IV, to be followed by a continuous infusion of 1,000 units per hour. Is this heparin dosing regimen appropriate? A loading dose of heparin is required for several reasons. Based on pharmacokinetic principles, a therapeutic serum level will be achieved more quickly. Thus, pharmacodynamic and therapeutic responses to help prevent progression of the clot will occur rapidly. Second, a relative resistance to anticoagulation exists during the active clotting process. Therefore, a larger initial dose generally is necessary to achieve a therapeutic effect. Although standardized doses of heparin for initiation of therapy, i.e., 5,000 units loading dose, 1,000 units per hour maintenance dose, were used historically, this approach can result in significant delays in reaching a therapeutic intensity of anticoagulation. Body weight represents the most reliable predictor of heparin dosing requirement. For patients who do not have extremes of body weight, i.e., below 165 kg, the use of the actual body weight, abbreviated as ABW, has been recommended to calculate the initial unfractionated heparin dose. For patients more than 165 kg, the use of the actual body weight is controversial, and the use of an adjusted dosing weight is recommended by some experts. Options include two different dosing weight calculations. Ideal body weight plus 0.3 multiplied by opening brackets actual body weight minus ideal body weight close brackets, or ideal body weight plus 0.4 multiplied by opening brackets actual body weight minus ideal body weight closed brackets. Compared with standardized dosing, weight-based dosing 80 units per kilogram loading dose, 18 units per kilogram per hour initial infusion rate, increases the frequency of therapeutic activated partial thromboplastin time at 6 hours and at 24 hours, and decreases the risk of recurrent venous thromboembolism. Initial heparin loading doses of 60 to 100 units per kilogram followed by an infusion rate of 13 to 25 units per kilogram per hour are commonly recommended. Selection of the lower or upper dosage range is guided by the severity of the patient's symptoms and his or her potential sensitivity to adverse effects. For this 92 kg patient, a mid-range loading dose of 7,400 units, that is, 92 kg multiplied by 80 units per kilogram, followed by a continuous infusion of 1,700 units per hour, that is, 92 kg multiplied by 18 units per kilogram per hour, is recommended. Loading doses are typically rounded to the nearest 500 units and maintenance infusion rates to the nearest 100 units for convenience of administration. Pause the video and carefully scrutinize the table below. The next question reads, the orders for JYT were rewritten by his attending physician. Based on the data shown subsequently, explain the variability in laboratory results. At this institution, activated partial thromboplastin time values of 60 to 100 seconds correspond with heparin plasma concentrations of 0.3 to 0.7 units per milliliter determined by antifactor 10A assay. Although the activated partial thromboplastin time drawn 1 hour after the initiation of the maintenance infusion at 9 a.m. demonstrates excessive prolongation of the activated partial thromboplastin time of 130 seconds, this value is most likely explained by inappropriate timing of the test. When activated partial thromboplastin time values are drawn too soon after a heparin bolus dose, i.e., before the maintenance infusion has achieved a steady-state concentration in serum, they are predictably very high, but are not associated with a bleeding risk and do not accurately reflect the anticipated level of anticoagulation in the patient. To ensure accuracy, the clinician should obtain activated partial thromboplastin time values no sooner than 6 hours after a bolus dose or any change in the infusion rate. Even results obtained at 6 hours may be excessively prolonged in some patients because of the dose-dependent pharmacokinetic characteristics of heparin. JYT's heparin dose was decreased at 9 a.m. based on this prolonged, yet inappropriately timed, value. A repeat activated partial thromboplastin time at 3 p.m. was only 40 seconds. The decrease in the dosage to 1,500 units per hour and the repeat activated partial thromboplastin time of 40 seconds reflect near steady-state conditions because 6 hours has elapsed since the dosage change. Because the activated partial thromboplastin time was subtherapeutic at 3 p.m. 40 seconds, administration of a smaller repeat bolus dose 2,000 units and an increase in the maintenance infusion to 1,700 units per hour was the correct course of action. Subsequent activated partial thromboplastin time values reflected therapeutic anticoagulation. Dosing nomograms or protocols have been recommended for adjustment of heparin dosing based on activated partial thromboplastin time results. Nomogram-based dosing reduces the time to reach therapeutic range compared with empiric dosing. Attaining a therapeutic activated partial thromboplastin time in less than 24 hours has been shown to lower in-hospital and 30-day mortality rates. After initiation based on patient weight, dosing adjustments may also be weight-based or may simply be made in international units per hour. A sample heparin dosing nomogram specific for a reagent with a therapeutic activated partial thromboplastin time range of 60 to 100 seconds, and used in the adjustment of heparin doses for JYT. Responses to changes in infusion rates of heparin are not always linear, and to some extent, heparin doses are adjusted by trial and error. As the patient's condition improves after several days and endothelialization of the clot occurs, heparin dosing requirements may decrease. The next question reads, how should JYT's heparin therapy be monitored? Once baseline clotting parameters have been established and a loading dose of heparin has been administered, the activated partial thromboplastin time should be measured routinely to guide subsequent dosing adjustments. The activated partial thromboplastin time should be evaluated no sooner than 6 hours after the loading dose or after any changes in infusion rate, as noted previously. If dosing is stable, the activated partial thromboplastin time should be evaluated once daily. Additional monitoring parameters for heparin therapy include evaluation for potential adverse reactions and possible therapeutic failure. The hemoglobin and/or hematocrit and a platelet count should be checked every 1 to 2 days. JYT should be examined for signs of bleeding, as well as for signs and symptoms associated with thrombus extension and pulmonary embolism. Finally, if unusual or unexpected activated partial thromboplastin time results are reported, the clinician should consider the possible influence of solution preparation errors, infusion pump failure, infusion interruption, and administration or charting errors in the assessment of JYT's heparin therapy. The next question reads, how long should heparin therapy be continued in JYT if the patient starts warfarin? Adherence of a thrombus to the vessel wall and subsequent endothelialization usually takes 7 to 10 days. However, anticoagulation therapy must generally continue for 3 months to prevent recurrent thrombosis. For many years, warfarin was preferred for this long-term anticoagulation because it can be administered orally, and it is generally initiated on the same day as heparin. The long elimination half-life of warfarin and the long elimination half-lives of clotting factors 2 and 10 necessitate a prolonged period of overlap between warfarin and heparin. Therefore, if warfarin is initiated, heparin is continued for a minimum of 5 days and until the INR is greater than 2.0 for 24 hours. If the INR exceeds the therapeutic range, i.e., INR above 3.0 prematurely, it is acceptable to stop parenteral therapy before the patient has received 5 days of treatment. The next question reads, on day 2 of heparin therapy, JYT's complete blood count reveals a platelet count of 180,000 per microliter, decreased from 255,000 per microliter at baseline. What is a reasonable explanation for this thrombocytopenia and how should it be managed? Let's discuss thrombocytopenia. Thrombocytopenia induced by heparin has 2 distinct presentations. Heparin-associated thrombocytopenia, abbreviated as HAT, occurs as a direct effect of heparin on platelet function, causing transient platelet sequestration and clumping with reductions in platelet count, but usually remaining greater than 100,000 per microliter. This reversible form of thrombocytopenia occurs within the first several days of heparin therapy. Patients remain asymptomatic, and platelet counts return to normal even when heparin therapy is continued. JYT's reduction in platelet count is somewhat modest and likely represents heparin-associated thrombocytopenia. His platelet count should be monitored daily, and heparin therapy should be continued. Reductions in platelet count of greater than 50% from baseline suggest the development of heparin-induced thrombocytopenia, abbreviated as HIT, a more severe immune-mediated reaction with a typical delay in onset of 5 to 10 days after the initiation of heparin therapy. In contrast, rapid onset heparin-induced thrombocytopenia can occur rapidly, within 24 hours of unfractionated heparin initiation, and is strongly associated with recent heparin exposure. And, delayed onset heparin-induced thrombocytopenia is associated with an onset of thrombocytopenia that begins several days after heparin has been stopped. Heparin use leads to the formation of immunoglobulin G antibodies that recognize multimolecular complexes of a platelet protein called platelet factor 4, abbreviated as PF4, and heparin that form on the surface of platelets. Antibodies against platelet factor 4 heparin complexes are responsible for the prothrombotic nature of heparin-induced thrombocytopenia due to their capability to induce platelet activation by cross-linking platelet FCC receptor 2A, also called CD32A, and release procoagulant, platelet-derived microparticles, resulting in a large generation of thrombin and the formation of venous and arterial thromboses. The diagnosis of immune-mediated heparin-induced thrombocytopenia is made based on clinical findings supplemented by laboratory tests confirming the presence of platelet-activating antiplatelet factor 4 heparin antibodies. The 4T score is the most common pretest probability test that can be used to estimate the likelihood of heparin-induced thrombocytopenia based on extent and timing of platelet count reduction, the presence of thrombus, and the possibility of other causes of thrombocytopenia. The overall incidence of heparin-induced thrombocytopenia is less than 3% after 5 days of unfractionated heparin use, but the cumulative incidence can be as high as 6% after 14 days of continuous heparin use. Despite its low incidence, heparin-induced thrombocytopenia is a life-threatening condition with a reported mortality rate of 5% to 10%. Venous thrombosis is the most common complication secondary to heparin-induced thrombocytopenia, with rates reported at 2.4 to 1 more common than arterial thrombosis, limb artery thrombosis, thrombotic stroke, and myocardial infarction. Limb gangrene has been reported at 5% to 10%, with a resulting risk of amputation. In patients who develop heparin-induced thrombocytopenia, heparin therapy should be stopped immediately, and treatment with an alternative anticoagulant should be initiated. Although associated with a lower risk of heparin-induced thrombocytopenia below 1% than unfractionated heparin, low molecular weight heparin products are contraindicated in patients with heparin-induced thrombocytopenia because of a high incidence of immunologic cross-reactivity with heparin. The future use of heparin in patients with heparin-induced thrombocytopenia, especially in the first 3 months after the diagnosis, should be avoided. Treatment options include the direct thrombin inhibitors argatroban and bivalirudine, although only argatroban is approved for this indication by the FDA. The dose of argatroban is administered as an IV infusion due to its short half-life and should be titrated based on activated partial thromboplastin time testing. Bivalirudine also appears to be a promising alternative for the treatment of heparin-induced thrombocytopenia due to its short half-life, low immunogenicity, minimal effect on INR, and enzymatic metabolism. Various patient-related factors, such as the presence of renal or hepatic dysfunction, drug availability, cost, and institutional preference, should be used to select the most appropriate agent. The next question reads, on day 3 of heparin therapy, JYT's hematocrit has dropped from a baseline of 37.5% to 28%, and the patient noted blood in his commode after urination. Describe an approach to evaluate and interpret this event. Let's discuss hemorrhage. Bleeding is the most common adverse effect associated with heparin. A summary of 8 studies reporting heparin-associated bleeding found the absolute frequency of fatal, major, and all, major or minor, bleeding to be 0.4%, 6%, and 16%, respectively. The corresponding average daily frequencies were 0.05% for fatal bleeding, 0.8% for major bleeding, and 2% for major or minor bleeding. Cumulative risk increased with the duration of therapy. The most common sites for heparin-associated bleeding are soft tissues, the GI and urinary tracts, the nose, and the oral pharynx. The use of different criteria to define major versus minor bleeding accounts for much of the variability in reported frequency of bleeding among studies. In addition to length of therapy, many factors influence the risk of bleeding during heparinization, including advanced age, serious comorbid illnesses, heart disease, renal insufficiency, hepatic dysfunction, cerebrovascular disease, malignancy, and severe anemia, and concomitant antithrombotic therapy. The incidence of unfractionated heparin-associated bleeding complications is minimal with subcutaneous prophylactic doses, but higher 2% to 4% with therapeutic doses given via IV infusion. Soft tissue bleeding commonly occurs at sites of recent surgery or trauma. Previously undiagnosed abnormalities, including malignancy and infection, may be identified in some patients with GI or urinary tract bleeding associated with heparin therapy. The influence of the intensity of heparinization on bleeding risk is controversial. Although an elevated activated partial thromboplastin time has historically been considered a risk factor for bleeding complications, several investigators have been unable to substantiate a relationship between supratherapeutic activated partial thromboplastin time values and hemorrhagic effects. In addition, bleeding episodes can occur when coagulation test results are within the therapeutic range. These conflicting results may be explained in part by the influence of additional risk factors for bleeding and by the effect of heparin on platelet function and vascular permeability. JYT has developed hematuria despite an acceptable intensity of anticoagulation. He should be questioned and examined for the presence of nosebleeding, that is, epistaxis, increased tendency to bruise, that is, ecchymosis, bright red blood in the stool, that is, hematochezia, black or tarry stool, that is, melena, or coughing up of blood, that is, hemoptysis. Blood pressure and pulse, both sitting and standing, should be obtained to determine whether orthostasis representing blood loss is present. A thorough evaluation of the urinary tract may reveal a previously unknown abnormality that will explain the bleeding episode. Although his concurrent low-dose aspirin therapy may increase the risk of minor bleeding complications, aspirin therapy would not be discontinued due to his history of coronary artery disease. The next question reads, what other side effects of heparin should be considered in JYT? Regarding osteoporosis, the development of osteoporosis has been associated with administration of more than 20,000 international units per day of heparin for 6 months or longer. Various mechanisms have been suggested, but the underlying pathophysiology of this rare adverse effect remains unclear. Affected patients may present with bone pain and/or radiographic findings suggestive of fractures. The possibility of osteoporosis should be considered in patients receiving long-term, high-dose heparin therapy such as pregnant patients, postmenopausal women, and elderly patients. Hypersensitivity reactions. Other rarely occurring adverse effects associated with heparin include generalized skin reactions that can progress to necrosis, alopecia, and hypersensitivity reactions, resulting in hypotension, nausea, and shortness of breath. In 2007, an increase in hypersensitivity reactions to heparin was attributed to oversulfated chondroitin sulfate in the heparin manufacturing process. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it, and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support, and kind collaboration. We look forward to interacting with you in the next video, which will be part 286.